Welcome to the instructional video on the intubating laryngeal airway, use of the intubating laryngeal airway with fiber optic intubation in children. Today we'll be talking about how to use this device in the face of airway crisis in various situations. We'll be talking about the equipment we'll need to provide an airway for children and the fiber optic technique we'll use for using this device as a conduit for critical intubation. This is the equipment that we're going to use for this demonstration. Here is the actual intubating laryngeal airway. This is the size 1, which is meant for the newborn child. We need a syringe to inflate the cuff. Always make sure you have some surgical lubricant to lubricate the tip of the mask, and as well as the endotracheal tubes. Here are two sizes of endotracheal tubes. Remember that the size of endotracheal tube that you want to place is actually on the mask itself, and it tells you the maximum oral endotracheal tube diameter that will fit in that size airway, and each size is obviously different. We have our ambu bag, which is going to be used for oxygenating and ventilating through the mask or through traditional mask ventilation. And this is our fiber optic scope along with its light source and camera, which you'll be using today for intubation. So this is our little patient here. He's a newborn baby, and we will be using him for demonstrating tracheal intubation through this device. So at the end of this demonstration, we would like the participants to be able to be proficient in use of this device in terms of placement, successful oxygenation and ventilation through this device, and then subsequent fiber optic intubation using the endotracheal tube, which will permanently secure the child's airway in a crisis situation. Okay. Before we start, we want to make sure all our equipment is ready in terms of the proper lubrication. So we have surgical lubricant, and there are 3 places that we want surgical lubricant to be applied. One is the actual endotracheal tube on the outer portion. The other portion is the outer portion of the actual intubating laryngeal airway, and then finally across the shaft of the fiber optic scope. Once that's done, we want to make sure that the actual tube fits in through the device and passes easily. Then we want to make sure that the tube passes easily over the fiber optic scope. So we'll be demonstrating the insertion technique of the device. Using your dominant hand, you're going to be placing the device. With your non-dominant hand, you can apply jaw thrust to lift up the posterior pharyngeal wall. If this is not possible, it's still okay to place the device without any jaw thrust. So the insertion is demonstrated like so. You place the device straight in the child's mouth, and there will be some resistance you'll encounter at the hypopharynx, but advance ever so slightly, and that is properly placed. Once you're placed, you want to inflate 3 cc's of air, and you will see a slight outward movement of the device, and that indicating an adequate placement of the device. The next step is to connect your ambu bag with an oxygen source and ventilate and verify that you see bilateral chest rise. And in this child, you can see inflation of the lungs. And once that's established, you know that you've created a conduit for oxygenation and ventilation until you can start using the fiber optic scope for securing the airway with the endotracheal tube. If you're having trouble placing the device and you meet resistance using the traditional technique, then I would suggest reversing the orientation of the device, place it backwards, and as you meet resistance, turn it either clockwise or counterclockwise to place the device into the hypopharynx. And Again, you want to inflate the device and then connect your Andrew back to verify bilateral chest rise. So assuming that you're ventilating reasonably with this device, we're going to now demonstrate flexible fiber optic bronchoscopy with intubation through the device. We're going to now remove the ambu bag, and then we're going to remove the adapter of the intubating laryngeal airway. I have my flexible fiber optic scope here, which I'll be inserting into the lumen of the intubating laryngeal airway, and I'm going to be progressing down the shaft of the device and keeping the orientation straight in midline, following the curve of the device as I approach the glottic opening and vocal cords. And once I see the vocal cords and have that visualized, I'm going to then proceed with the fiber optic scope into the vocal cords until I visualize the tracheal carina. Now we'll be demonstrating the endoscopic fiber optic view of the device. We're going to be placing the fiber optic scope into the lumen, and as I'm progressing down the airway, we want to be able to make sure that we're able to read the writing, and the writing should be in the 6 o'clock position, indicating proper orientation of your fiber optic scope. Remember, the distance between the actual device into the laryngeal inlet is quite short, so you want to be able to progress down the airway in a relatively slow fashion and be able to visualize the glottic opening. And once you see the glottic opening, that's your cue to proceed into the glottic opening where you can be able to see the carina. Okay. Now we'll be demonstrating the actual tracheal intubation portion of the procedure. I have a endotracheal tube loaded onto the fiber optic scope, and this will be used for tracheal intubation through the intubating laryngeal airway. Again, I'm going to be placing the fiber optic scope in the lumen of the device, making sure that I'm in proper orientation by looking at the screen and making sure that I'm able to read the lettering across the 6 o'clock position. And as I'm progressing, I slightly flex my scope and enter the vocal cords into the trachea. Once I enter the trachea, with your dominant hand, you want to proceed and place the endotracheal tube down the device, and once you place it down the device, you want to be able to see on your screen both the carina as well as the plastic of the endotracheal tube, verifying the tracheal tip is above the level of the carina and indeed in the lungs. I would remove the scope and then oxygenate and ventilate through the endotracheal tube, confirming proper tracheal position. So at the end of this video, we'd like you to be able to place the intubating laryngeal airway and then use it as a conduit for oxygenation and ventilation. Then subsequently use this device as a conduit for tracheal intubation using the flexible fiber optic scope. So at the end of this demonstration, both of these skills should be relatively easily acquired by the participants involved in this study.